All right, good afternoon, everyone. Thank you very much for your patience. It is time for our 2 o'clock meeting of the Santa Clara County Health and Hospital Committee. First item of business, item number 1 on the agenda, is the call to order and the call of the roll to establish the presence of a quorum. So, Mr. Clark, help us out.
Chairperson Simidian?
Here.
Vice Chair Ellenberg?
Here.
Thank you. You have a quorum.
Thank you very much. The presence of a quorum having been established, that takes us to item number 2, which is public comment. Public comment, of course, is that portion of our agenda set aside for comment by members of the public on non-agendized items that are properly within the jurisdiction of our county. And we have 2 cards today under public comment. One is from Scott Largent, and the second is from Raimundo Espinosa. So, gentlemen, if you'd like to come forward, please do. Mr. Largent, come on up.
Ready when you are, Frank. Thank you. Thank you. Good afternoon, everybody. Scott Largent. We're just going to talk about the new homeless encampment that we have within football throwing distance right here. Actually, you know what? Maybe I will talk about that. I finally got to see the hospital van that comes out to pick up homeless people to take them to their appointments. Now, I haven't seen the behavioral health bus. Robert Aguirre and I, we've been looking everywhere, and hopefully we find it. We don't think it exists. But a woman, bless you, Susan, a woman got dropped off right near the bridge over here at 87, and the Valley Health van pulls up. She gets out of there. And of course, I'm running down the road. I'm just amazed to see this thing. The gal got out. She started walking down the trail. And I try to be polite, and I just basically said, hello, ma'am, I noticed you were getting out of the van. And she starts telling me more about, oh, yeah, they picked me up. They took me over to the hospital. I had some medical appointments. And I thought that was really neat. She started to open up more about her story of what's going on in her life. She actually has a pretty decent trailer over there. She also has a Ford pickup truck that's not too old and a BMW. She was employed up until about 1.5 years ago. She got in a really bad car accident. She had a lot of really bad health issues, and life just got rough for her. So that gardening supply place, I'm sorry, not the gardening supply place, there's like a law office right there, and then there's a plumbing supply thing right next to the creek. She's camped out behind there, okay, and she's been staying there for about 1 year. But with where she's at and her little neighbor right there, you go about 50 feet over, and it's like Lord of the Flies. I mean, you have some guy out there with 6,000 bikes, and he's sharpening machetes. And then you go a little farther over, and then there's another woman, just trying to survive. Really nice gal. So it's kind of, why do we not, I'm not saying to go over there and sweep that all out, but this really nice woman that has no criminal record, that's going through health issues, that has a nice trailer and nice vehicles, why are we not providing a spot for her to go that's safe, well lit, drop her some power, give her a porta potty, give her a little bit of security? It's frightening where she's at over there. There's no lighting over there. You have now, I'd say roughly about 400 people living over there. And what's going to happen? Are you guys going to go through there and sweep all these people? Because they're going to end up behind here. They're going to end up everywhere around here. I don't think there's very many options. And Joe, I heard you on the KCBS, and you were talking about the people living in motorhomes and cars. But this has been going on, Joe, for 3 or 4 years. So it seems like you're kind of late to the game getting out there on the media. It's damage control time. We really need to start helping these people because they're dying in these fields. Silicon Valley. Thank you.
And our next speaker, Raimundo Espinosa. Mr. Espinosa, there you are.
Good morning. My name is Raimundo Espinosa. I'm actually here on behalf of Dolores Alvarado, who is in D.C. But basically, we wanted to take this opportunity to thank you all for facilitating the interaction between the Community Health Partnership and county administration. We really want to thank you, Supervisor Simidian, for inviting us to present in March. And I think it really it was really productive, and regarding our fiscal year 20 contract, and I think it set a precedent for the future. And really want to thank Dr. Smith for taking the time to meet with us and resolve many issues that we had. And I think, I think we're moving in a very, very positive direction. And I think we're looking forward to a joint planning session where hopefully we can further define our roles and responsibilities to create hopefully a unified strategy for creating a healthcare system for all in this county. And we normally come up here and have issues, and we have no issues. We want to just say thank you for your efforts to make it better. And thank you.
Thank you very much. And before you step away, Mr. Espinoza,
Pardon me?
before you step away, I did just want to say, I mean, thank you for the acknowledgement of progress and the kind words for all who've been part of that, including the various members of the partnership. But it really was a hope at the beginning of my tenure last year as chair of the committee that we could use the committee as a venue to have hard conversations. And, by definition, hard conversations are hard.
Yeah.
And they're not always comfortable. But it did seem to me that if we could get the right dynamic in the room, we could tease out some lingering issues and maybe make a little progress. So, we still have work to do on these issues, as you've suggested, but it's gratifying to think that maybe we actually can use a public meeting as a way to have a real conversation.
Yeah, yeah. And we want to deal with hard issues too, because it'll facilitate progress, hopefully.
All right.
All right.
Thank you very much.
Thank you.
That is the last card we have, Mr. Clerk, under public comment. We do have item number 3, which is to approve the consent calendar and changes to the committee agenda. And our consent calendar today consists of items 9 through 15. And after we hear from Mr. Largent, who is the one card we have on consent calendar, I'll ask for a motion to approve the consent calendar, also with one adjustment, and that is that on our agenda schedule, item number 7, which deals with the Behavioral Health Services Facility on the VMC campus, will be heard at 3 o'clock as a time certain item. That may affect how long some of you are obliged to wait for your items to come up, and I regret that, but for a variety of reasons, we're going to take that item up at 7 o'clock, at 3 o'clock, item number 7. 7 o'clock would be a long wait. 3 o'clock for item number 7 if my colleague is agreeable. But meanwhile, Mr. Largent, why don't you come on up? You have a card in on the consent calendar, sir.
Okay, thank you, everybody. Scott Largent. On the consent calendar, what kind of caught my eye was the approval for the policies and procedures at Valley Medical Center. The reason I'm coming up here to talk about that is we have a lot of, throughout our county, procedures and protocols that make things very difficult for the homeless community. Some examples are that unconstitutional order from the courthouse that makes it difficult for anybody to basically be out in front of there, including shopping carts, more bags that they need to have with them. This makes it difficult for anybody to even go to court that's homeless. At our library, the San Jose State Library, which is also a City of San Jose library, it's a joint partnership. Their procedures and protocol that they have in their library make it very difficult for homeless people to film misconduct. I right now am going through a 30-day suspension for filming the police in the library harassing homeless people and giving them a hard time. We had another gentleman that was basically damn near beat to death in that library, and I believe they paid him out close to $1 million, but the public didn't find out about that for several years. When you guys put this in together, and I'm not sure, I didn't read it in the back, we should just think about how hard it is to just get around when you're homeless and what you're going to bring with you, how you're going to look. We should need to take that into account. Not everybody's going to be showing up wearing a brand new suit and standing in the front of that hospital there in the brand new wing. So I hope you guys do that, and I hope you don't make it very difficult. I know it's a hospital, but there are common areas that are lobbies. There's areas where law enforcement interacts with the public more, and people want to hold them accountable. They film us, we want to film them, and I hope you guys think about that. So thank you.
All right. I'm going to choke. I'm glad to do it surrounded by healthcare professionals, I guess. So, could we get a motion to approve the consent calendar as contained in our published agenda?
So moved.
with item number 7 being set as a time certain at 3 p.m. Is that agreeable? That is the motion, Mr. Clerk. I don't believe we have any other cards on the consent calendar. If not, all those in favor, please say aye. Aye. Are there any opposed? There are not. And that passes unanimously. So that takes us next to item number 4. And as it happens, we're all teed up. If you'd please introduce yourself for those who may not know you and provide your title and share the report.
Good afternoon, Board of Supervisors. My name is Yvonne Karanis, and I am the president of the Enterprise Medical Staff, and I'm here to present the credentials report as well as the Enterprise Anesthesia credentials. Answer any questions about them.
Thank you very much. I don't believe we have any cards on this item, Mr. Clerk. We do not. Comments or questions, Supervisor Ellenberger? Would you simply like to make the motion to approve the appointments and the criteria is contained in our published agenda?
So moved.
Then there is a motion to that effect. I'm happy to second without objection, and hearing none, unanimously approved.
Thank you very much.
Thing you very much. That takes us to item number 5, which is to receive the report from the Valley Health Plan relating to the 2019 annual operational report. And Dr. Smith, who's going to present on this one? All right, do you have a microphone that works down there?
Laura Rosas is going to do it, our Director of Valley
There
Health
we go.
Plan.
Thank you.
Thank you so much. Next slide. So today I'm going to cover California, no pun intended. HEDIS measures, our women's health work group, including breast cancer and cervical cancer screening campaigns, enrollment, and financial status. So since 2014, Valley Health Plan has offered a covered California qualified health plan. That was the first year that the Affordable Care Act went into effect. So we were one of the first plans. We are still the most affordable option in Santa Clara County. So that's something that's very important to us. And for our current open enrollment season, our goal has been 18,000 members. We believe we will be surpassing that and exceeding that benchmark, which would show a 7% growth by the end of January, which is the end of enrollment. We've been very successful this year in our enrollment, partly because of the state subsidy, which has increased the affordability of covered California. Also, we have an auto pay feature. It's very important for members to be able to pay, since this is not coming out of their paycheck, they need to pay this themselves. And so this is a very convenient way for them to manage their payments online. We also have improved our broker relationships by highlighting our rate position, expanding our provider network, offering new products and improvements, and really trying to be more accessible and listen to their concerns. We have, I think this is unique to Valley Health Plan, we have orientations for new members so that they can better understand health coverage. Many of them are new to having health coverage, so this helps them understand in a face-to-face venue how to choose a primary care physician, paying invoices, how to receive specialty services or have referrals authorized, and accessing pharmacy benefits and laboratory services. Also, another aspect of Valley Health Plan's report this year is our Healthcare Effectiveness Data and Information Set, or HEDIS. These are a set of standardized performance measures designed to ensure healthcare consumers have access to reliable information about their plan. These are required to be submitted to NCQA, or the National Committee for Quality Assurance. They are the accrediting body for health plans, as well as the Center for Medicare and Medicaid of the federal government. A subset of HEDIS data is collected and reported to CMS for the exchange line of business, which is covered California. And we monitor and track HEDIS scores to evaluate our clinical effectiveness, performance, and other dimensions of care. So some of the highlights I wanted to present today on our commercial product is our prevention and screening. 7 out of 11 measures improved during the 2019 HEDIS season, including childhood immunizations, counseling for physical activity, and screening for HPV, or human papillomavirus vaccine. And our diabetes to identify poor control improved by 7% and was rated at the 95th percentile. And our HB1C control was improved by almost 12% and was rated in the 90th percentile. Respiratory conditions, medication management for those suffering with asthma improved significantly by 30%. In addition, we've been working hard on breast cancer screening and cervical screening. In July of last year, we formed a multidisciplinary women's health work group to evaluate our previous breast cancer screening activities and interventions. These interventions were refocused to target the HEDIS population, which were ages 50 to 74, with the goal of really improving the HEDIS measures for those at screening for the commercial and covered California line of business. So we identified a baseline population of 2,300 eligible members who had not received the screening in the time frame that they should have. And then by the end of 2019 third quarter, the baseline population who had not received screening had been reduced by 9.6%. So that brought down the number of members who were in that gap. Fourth quarter will be finalized. We're looking at that analysis now and then presented at the Quality Management Committee in March of 2020 and subsequently here at our next appropriate meeting. Some of the highlights of this effort has been collaborating with Santa Clara Valley Medical Center to implement an automatic referral process and improve appointment scheduling and to reduce one of the barriers of being screened and receiving a mammogram. Collaborating with VHP utilization management to remove all the authorization requirements for mammography at any age so that physician orders would just be processed more quickly. Contracting with a mobile mammography vendor to make sure that we had mammography services available where our members are. Securing assistance with mammography centers to ensure reaching out to members to schedule mammograms, and updating our member services call center hold messaging, so while people are on hold, they would actually hear reminders about getting a mammogram. So we really tried to tackle this from multiple communications. We also had, we created a direct mail postcard. We changed our landing page on the breast cancer screening at the VHP website. We have utilized our case management vendor to send targeted text messaging. We've seen this be successful in other areas in healthcare, such as Text for Baby, where people were reminded to bring their child in for immunizations. We find this is usually very effective. So we did this with the breast cancer outreach, and we went to a number of events, including the Sobrato Cancer Center in October at VMC. And we're continuing to offer incentives to members to get a mammogram and presenting at the Information Member Advisory Board, which we just had a meeting last week. So those are some of the ways that we've been trying to outreach on this. You can see here some of the numbers on the Care Gap Finder and the criteria for who would fall into this care gap, which would be women 50 to 74 who had not received a mammogram in the previous 2 years. Next slide. And here you have our HEDIS measures on breast cancer and cervical screening. So we definitely have improved. We're not quite at our goal yet, but we're very close on on 3 of these, with more work to be done on cervical screening. Another area of improvement has been enrollment. We have our enrollment numbers for Classic for Commercial Classic, which is our employee benefit, and Commercial Preferred, as well as Covered California. These we expect will be, certainly for Covered California, will be significantly higher going into the next year, into this coming year. And our government program is, of course, Medi-Cal. This is our total of enrollment by percentage of enrollment. You can see the government program is a large majority of our members, but our Covered California is also growing, as well as our employee benefits program. So our
So I
financial
just want to
data.
interrupt quickly. What you're referring to as government program, is that Medi-Cal?
Medi-Cal, right.
Is there a reason that you're not calling it Medi-Cal?
I think it's a term of art. Sometimes we refer to, it's covered, sometimes when we call it commercial, we usually term our Covered California and our employee benefits program, as well as IHSS. But it's really Covered California in a sense as a government program. But so we
Right.
usually say government program for Medi-Cal.
Thank you.
And so these are some of our financials. There was an increase in the rate of about 10.3 million that ended up, so there increased, changing some of the offsets, but you'll see it true up in the next report. And this is our financials for the end of the year. I can take questions. Thank you. Thanks so much, Anna.
Excuse me, I have just one before I turn to Supervisor Ellenberg again. I'm looking at page 10 of the slide deck here, the HEDIS measures, packet page 53 for anyone who's using their packet pages, and the breast cancer screening number, which you referenced earlier, if I read the chart right, indicates that our 2019 score has us at the 33rd percentile as compared or contrasted among commercial plans. Do I have that right?
33rd.
Under 2019 score, it says 73.73%, and then it says 33.33 percentile.
So we were at the 71st percentile. We have, I think what this means is that our screening has been at 71%, but it should be, the 50th percentile would be 74%. So right, we are at the 33rd percentile.
Okay, well, I'm just going to be very direct here. So the 33rd percentile means that we're in the bottom third in terms of the HEDIS measures for breast cancer screening. And the performance goal is that we get to the 50th percentile. And I guess what I'd like to ask is, what would it take to get us to something better than the 50th percentile? And what kind of timeline should we be looking at?
I totally agree. And the focus for this coming year is to build out our case management capability and bring a lot of that focus in-house.
Okay. How often does this analysis get done in terms of the percentage and percentile score? Is that a quarterly or annual number?
I believe it's annual, but I think we are constantly working on our HEDIS numbers for our commercial products, and it's something we keep a close watch on.
Thank you. I'm going to ask for an off-agenda report, and I'm going to look to my staff who are here to make sure that they keep an eye out for it and share it with me. Of course, if it's an off-agenda report, it's a public document and gets posted as such. But I'd like to see, I'd like an indication on how often this number can be updated, and I'd like to ask that it be updated as routinely and regularly as possible, and then that the percentile score as well as the actual percentage of enrollees be provided, because while there's a lot about the plan that we can brag on, bragging about being in the bottom third on breast cancer screening is not one of them. So I'll just let it go with that. Supervisor Ellenberg, comments or questions?
Thank you. Some of each. Staying with that same slide that Supervisor Simitian just asked us to look at, I see that the breast and cervical cancer numbers that are there, the focus in the reporting are really specific to commercial and covered California members. And this doesn't even include the government or the Medi-Cal piece. Are there outreach and support strategies, or are the outreach and support strategies that you described for the other products being applied to all of the VHP lines of business, including the designated Medi-Cal members?
So for Medi-Cal, that would be under FHP, since they enroll the members, and they also have not delegated quality to us. So we have, but I can find out more. Oh, sorry, you can't hear me, can you? So I will find out more about that, but that is my understanding.
All right, then that may be a question that I circle back to once we've also heard from FHP about that split of delegation, and wanting to make sure that there is clear ownership somewhere. And I appreciate the highlighted areas of improvement. I'm also interested in what are the gaps that still need to be addressed? What do you see as
Absolutely.
the most significant challenges right now?
Right, and I think I would like to put together a fuller report for you. I think, and we can do that in the off-agenda report. We can really highlight where some of our priorities are, where the gaps are, and what some of our plans are to reduce those gaps and to address those issues.
Would you like that in a separate off-agenda report from the breast cancer screening timeline?
Happy to get it in the same report if that makes for, ease of access and, we don't have multiple reports. I just would insert, since you've given me the opportunity, I did not mention the cervical cancer screening numbers, which actually are even somewhat lower. So I'd like to have the same analysis that I asked for with respect to breast cancer screening, both as to percentages and percentile, incorporated in the same document. And thank you for letting me piggyback on that.
Sure. And I have just one more question, Laura, but this, I think, rather than answering now, I'll just pose it, but should also be in that report. I'd like to know if VHP has a core set of performance measures that you're going to be using to monitor progress internally on an ongoing basis. We know that some new elements have been added to the recent monthly report to HHC on member calls and grievances. So I would like the report to include what elements you see as important to monitor and what that process will look like.
Absolutely.
Thank you.
Thank you.
Well, let me just double check. Anything else that VHP would like to present or share at this time, or does that complete the report for you?
That would complete our report.
All right.
Thank
then,
you very much.
Thank you. Supervisor Ellenberg, if you'd like to move that we receive the report.
So moved.
Without objection, hearing none, and no cards on the item, then without objection, so ordered. The report is presented and received, which takes us to item number 6, which is to receive the report from the Santa Clara Family Health Plan. And we'll ask those folks to come on up, take a place that's comfortable with a live mic. And thank you for joining us today. Please provide the report, and then as it happens, we're going to just so people are clear, we won't interrupt the report at 3 o'clock. We'll finish off the presentation and the questions and receipt and take formal action on that before we move on to item number 7. So if we can ask the folks from Family Health Plan to introduce themselves by name and title, please, and then feel free to share what you have.
There we go. Good afternoon. Christine Tomkala, CEO of Santa Clara Family Health Plan.
Dave Cameron, CFO of Santa Clara Family Health Plan.
I'm Laura Watkins, Vice President of Marketing and Enrollment, Santa Clara Family Health Plan.
Tyler Haskell, Director of Government Relations with Santa Clara Family Health Plan.
Wherever you came from, you weren't very well trained, Mr. Haskell. So. Welcome to you all, and thank you. Who's going to begin?
Thank you. So, with our PowerPoint for you today, we'd like to give it a little overview. And starting out with our background, as you know, we were created by the Santa Clara County Board of Supervisors as a public agency a little over 20 years ago. And we work in partnership with our providers and community organizations to improve the health and well-being of the residents of our county. We are in a 2-plan model county, and so we are the not-for-profit alternative. Anthem is our commercial competitor, and we maintain a 79% market share for both our Medi-Cal product line and for CalMedi Connect, which we'll get to in a minute. We do have a 13-member governing board, which the supervisors appoint for us. And moving on to the next slide, Laura. Our current enrollment stands right around 240,000 members, and the bulk of those fall within Medi-Cal at 231,000. We also have approximately 8,400 members who are duals. They have both Medi-Cal and Medicare, and they are in our CalMedi Connect product, which also maintains a 79% market share. As you can see from the heat map, the areas of red are where we have a concentration of membership, and that is on the east side of the county as well as to the south in the Gilroy area. But this just displays for you a little bit where our members reside.
And excuse the interruption. I just want to make sure I'm reading this right. The key on the left indicates the number of folks per color. That's not per anything. I mean, so when I look at the two red areas in East San Jose and in Gilroy, East San Jose and Alum Rock, so is that greater than 11,001 in each of those places or cumulatively? Sorry to...
That's a good question, and we should correct the legend or clarify the legend. It's per zip code.
Per zip code.
Per zip code.
Okay.
So you have varying numbers of zip codes in each of those areas depending on density. But
So that's not a raw number I should use. What I should do, say to myself is if I'm looking up in Palo Alto, which I represent, or Los Altos, that's not a good choice, Cupertino, which I also represent, in those cases, that per zip code there are between 1,501 and 3,500 folks who are members, yeah?
Correct.
Got it. Thank you. Sorry for the interruption.
All right, moving on to the next slide. We have all the kind of providers you would expect, a full range, and we pay our providers either through capitation, which is a fixed amount per member per month, or on a fee-for-service basis, which is payment for a claim once there is a particular visit. And on the next slide, you can see the distribution of where our members are served. So if you start on the left side, you can see that we have some of our providers under direct or medical group contracts, and they serve approximately 15% of our enrollees. In the middle, you can see that about a quarter of our members have a primary care physician in an independent practice association. And the IPAs bring to us a combination of both primary care services and specialist services. As we move on to the right side, we also contract with networks that provide both physician and hospital services, and they serve a little over 60% of our enrollees. 11% are with Kaiser, and then you can see that 50% of our members are served in the Valley Health Plan network. And that includes both the health centers through Valley Medical Center as well as the community clinics. As we move on to the financial overview, you can see that capitation is varying depending on the characteristics of the particular member. So it could range from $100 for a child up to maybe $10,000 a month for a long-term care member. And we do update our rates annually. But in general, of every $100 that we spend, according to our fiscal 20 budget, approximately $94 goes to member benefits and services, approximately $6 is spent on administration, and less than $1 is retained for reserves and strategic investments. And I just wanted to point out a couple of those. Our Community Resource Center is something new. We have obtained some space at the corner of North Capitol and McKee in what was formerly the Hometown Buffet. And this is a particular facility where we would like to provide a variety of services to the community and to our members, where they can get customer service, health education classes, and so forth, and also partner with some other community organizations to provide a meeting space and things. We are happy to announce that Blanca Alvarado has agreed to allow us to name the Community Resource Center after her and the good work that she's done for the community. The board has also set aside $20 million in Community Health Investment Program, and this is designed to collaborate with community partners to address gaps and opportunities in achieving quality healthcare outcomes for our county residents. And we mentioned Lee Avenue. That's a housing initiative we've been collaborating on for several years, but this is the kind of activity that we could fund through that Community Health Investment Program. And it also includes special project funding for CBOs. So if they have some great ideas to present to us, we're happy to entertain that as well. Moving on to the changing population. If you go back to 2013, before the Affordable Care Act, you can see that 64% of our enrollment was children. And after the Affordable Care Act, our Medi-Cal membership changed quite dramatically. In addition to growing a lot, you now see that only 40% of our members are children, and 30% of our enrollees in Medi-Cal come to us through the Medi-Cal expansion program. In addition, you can see there's 20% that are aged and disabled, and another 10% adults. So it's really changed the type of services that we need to provide to our members in terms of having many more folks that have chronic illnesses and disease burdens beyond those you'd normally find in childhood. We also focus a lot on quality in our organization, and there are 4 particular focus areas that we're looking at. And partly it's because quality is really important and we want to focus on it for our members anyway, but also Governor Newsom and his administration has made a very big push on quality. And so they've recently doubled the number of reported HEDIS measures that we report to the state, and also increased the required performance levels for several of them. So the expectation now is that the governor would like to see all of California performing at the 50th percentile or greater on HEDIS measures. So there's a focus on 4 areas with a special emphasis on early childhood development, and including increased focus on adverse childhood events, the ACEs screening, including some money behind that to help encourage providers to provide that to the enrollees. So some of the challenge that we share with the county and with our plans around the state is a decline in Medicaid enrollment. And you know, there are several reasons we believe that are behind that. Some of them include the federal public charge final rule and some of the uncertainty and concern that our members have regarding that. But then on the good news side, we also have increases in minimum wage and decreases in unemployment here in Santa Clara County, which means that some of our members now have a high enough income they no longer qualify for Medi-Cal. But also we're in a very high-cost county, and so we are also seeing some of our members leave the county to live in another community that's a little bit less expensive. So a variety of challenges there. We are also very focused on what was formerly known as CalAIM. Now it's the Medi-Cal Healthier California for All. And we wanted to include this paragraph up front because whatever our thoughts about it, we try to take a look at what the state and DHCS's intent is behind the proposal. And so you may get to some of their motivation by taking a look at this particular paragraph. So I leave it there for you to read. There are 22 proposals in the Medi-Cal Healthier California for All, and we're primarily focused on the 7 that you see here. And we can move on because there are quite a few. Let's take a look at the timeline, and you see some of them are front-loaded in the first 2 years. And we understand that there will be a more comprehensive discussion, I believe, on CalAIM and at the March Health and Hospital Committee meeting. So I'd like to today just focus on the one with the nearest deadline, which is the enhanced care management and in lieu of services. And you can see that transition plans are due to the state in July of 2020, which is not that far away, with statewide implementation by January of 2021. So first of all, there's the Whole Person Care Initiative as well as the Health Homes Program services that will be transitioning to statewide benefits. And this is really recognition by the state of the success of the pilots and their desire to see them implemented statewide. So kudos to Santa Clara County for the good work that's been done on whole person care here. So because we already have infrastructure in place, we think that, and the intention is for existing services to continue under managed care oversight. We are holding a series of meetings with county staff to work on the transition. Our first meeting was last Friday, and we enjoyed meeting with folks and are looking forward to continue to work with them to produce a solid transition for whole person care by July, and also to pave the way for collaboration in the years ahead as the rest of these play out. There are some additional challenges and opportunities we just thought we'd be remiss if we didn't mention. Some of them include the Texas versus Azar case, which threatens the entire ACA, especially Medicaid expansion, and as we noted, that's 30% of our enrollment. So that will be going back to the Supreme Court at some point. The Medicaid Fiscal Accountability Rule, otherwise known as MFAR, could also be finalized this year, and I believe there have been reports to this body on the concerns and the impact that could have in terms of dollars available to Medi-Cal. At the state level, we've mentioned the new quality benchmarks, and that is one of our areas of strategic focus going forward. Of course, there's the Medi-Cal Healthier California for All, which doesn't roll off the tongue easily. We need an acronym for that, I think. So we'll be spending lots of time and energy over the next few years working on the sweeping changes proposed by that. Medi-Cal RX is also a focus area with the state selecting a new contractor to take over the Medi-Cal pharmacy services for all the health plans across the state. So we'll be working on transitioning our pharmacy services out of the plan. And then lastly, there is the Healthier California for All Commission, which is exploring the plausibility of a single payer system in California, and we believe it has its first meeting at the end of this month. So those are some things that are on our radar to pay attention to going forward. And with that, I open it up for questions.
Supervisor Ellenberg, I'll turn to you.
Thank you. Thank you for the report, Christine. Can you talk a little bit about what steps overall a family health plan is taking to prepare for the changes that are proposed by CalAIM, and how do you see that work developing in relationship to the county, your delegate agencies, and local stakeholders?
Certainly. So far, we have been participating in the stakeholder groups where we can at the state level as well as at the county level. We know that there's a lot of input being provided to the state, and so there are some changes being made. Like one of the things we've heard is that the annual open enrollment we anticipate may fall off. So there'll be some changes going forward, but nevertheless, the bulk of it we know will be moving forward according to the timeline we shared. And again, we're trying to meet with the county and work on an ongoing basis to try to make the transition as smooth as possible. I think that there are still a lot of things that are unknown because the proposals are still being refined, and it's pretty fluid, but we vow to work collaboratively with the county as well as the other organizations in the community to make sure that we can implement all of the things set out.
Good. I'm glad to hear that. Are there specific areas of shared work between, and I'm happy to hear from Laura as well, between VHP and Family Health Plan that have been identified as priorities for 2020, specifically jointly?
Specific to the CalAIM proposal or broad?
Or other areas of shared work? I'm just looking to see where the two plans and entities have the opportunity to work together.
Certainly. So with respect to the CalAIM, as I mentioned, the first area of focus is transition of the whole person care and health homes. On a more day-to-day basis, we'd like to work collaboratively with Valley Health Plan, first of all, in quality. Let me back up. As an organization, the two most critical priorities that we have and have had over the last few years is to focus on both quality and compliance. And so quality, as we define it, is a combination of HEDIS scores, and we are very anxious to try to get all of the scores up. And just sort of responding to Laura's report, we do sort of hold quality at the organizational level, but we can't do it without our providers either. So we have a number of initiatives where we have member incentives. We advertise this in our newsletter that I know Laura can speak to. We do different activities like that. We have pay for performance with many of our providers. We produce report cards to give feedback to the providers. And so, we want to be working collaboratively with Valley Health Plan as well as with our other providers because we can't do it without them. It's the physicians that need to be providing these services. We try to educate the physicians to make sure they're aware, and we do different activities, clinic days sometimes, and other things to try to encourage closing the gaps on some of the measures where our members are not necessarily getting some of the wellness services we'd like to see them get.
So you could fill in the information that wasn't in Laura's report, specifically with respect to breast cancer screening and cervical screening for Medi-Cal recipients?
I don't have that data with me here. We'd be happy to share it with you outside of this meeting. I just didn't bring it with me.
Oh, sure, that's just fine.
And the one other thing I'll mention too is Prop 56 funding is also helpful, and we mentioned the ACEs screening. There's also the childhood developmental screening, which is very important, and we're trying to work collaboratively on that. We have a meeting coming up with First Five and the community clinics, encouraging, changes in procedures to make sure that the kids are getting those services as well. And there's this extra funding to help support the cost of doing that.
Are you part of that, the joint county application for?
Sorry, say again?
Is Family Health Plan part of the county and First Five's joint application for funds for capacity building with regard to ACEs? I'm guessing not, since that wasn't
I'm a little
familiar.
confused by the question, so perhaps we're not, but we are, as I say, working collaboratively, so maybe that will be part of what we continue to work on with them. I'm
Okay,
not sure
so I'm
where they are
talking
with
specifically with regard to capacity building around ACEs
Yes,
screening
so
for providers.
I'm not familiar
Okay.
with that aspect.
Supervisor, if I may
Please.
respond, that is a longstanding partnership that we have with the First Five, Behavioral Health, Public Health, and a variety of Healthier Kids Foundation. And we certainly welcome FHP and the other managed care plans to step up to the table. It started from the board's direction to expand universal screening for kids, and so it is part of our quality initiatives here. It's been mostly directed for county-operated ambulatory care centers and some of our community clinic partner sites. So we're looking for opportunities to expand it to all kids in our community.
I would think that the primary audience should be children on
Absolutely.
Medi-Cal.
We'd like to be able to get all 500,000 kids.
Right, and if I'm understanding correctly, we're not assessing the quality of care with regards to kids that are covered by Medi-Cal, that FHP is monitoring that quality?
Well, there's some very specific HEDIS measures related to prevention and screening for kids that are also crossover with some of the public health and child health and disability programs. And those are specifically targeted for the Medi-Cal kids. And so there is that particular effort. But the gap that we identified was not the physical screening so much as the behavioral health screenings for kids to identify early behavioral health issues with kids. And that's what the ACEs has been focused on. The grant opportunity that we're looking for.
Give the interruption if I may, just because Supervisor Ellenberg asked a question and then I realized I was confused by the answer. But who's responsible for the quality measures, which I thought was an important embedded part of the question, if I was hearing the question right, yes?
That was the second part of the question, yes.
So Santa Clara Family Health Plan is responsible for the overall quality of service provided to our membership. We try to do that in collaboration with the provider network, all of our provider networks, because it is the providers that have to actually perform these services, be they immunizations or mammograms and so forth. So we try to work hand in hand, but we are actively monitoring them to see that our scores go up. Where there are gaps. And
Supervisor Ellenberg, I apologize for butting into your question, but I really want to nail this down with you if I can. The HEDIS scores have to be reported, yes, no?
Correct. We as a health plan have to report them to the state.
Thank you. And does the Valley have to report the same numbers, or is that responsibility exclusively yours under the regulations?
That responsibility is ours under our contract with the state for Medi-Cal.
And you do that by, in part, gathering data from your partners, yes?
It's primarily based on encounter data, otherwise claims or encounter data, supplemented by lab data. And one of the things we've been working with the county on is to improve supplemental data sharing so that we can get like lab results and things to make sure that we are actually capturing all of the services that have been provided so that our HEDIS scores are reflective of the services that our members are receiving.
And I'm not suggesting that the quality measures are inappropriately low, but are there consequences or measures that are taken through HEDIS or another structure if the quality measures are at a level of concern or are not up to a level of satisfaction, I should say?
So,
I don't know why I looked at you, Paul. You were just smiling.
Okay.
So interpreting your question, our understanding is that state is as part of their quality initiative is going to start fining health plans if we do not meet the expectations for the quality measures. And they also, the state has an algorithm for any of the incoming enrollees that do not select a health plan. So if they don't choose our plan or they don't choose Anthem, the state will auto-assign them to a plan. And they use HEDIS performance as their algorithm for deciding how many of those, what percentage of those enrollees come to our plan versus go to Anthem. And so keeping our HEDIS scores up in these particular measures also helps drive additional membership or enrollment.
Okay, I'm going to stop there. Each time we talk about these two plans, I understand a little bit more. Give me 3 terms and I will be a professional. I meant 3 years. 3 months?
So, Ms. Tomkala, it's fair to say then that between the Santa Clara Family Health Plan and the folks at Anthem, that's where all our Medi-Cal people are, right?
Essentially, yes.
Okay. In terms of the Santa Clara Family Health Plan, understanding that you delegate a considerable number of those Medi-Cal folks, do you have the any thoughts you could share about the challenge or not of finding an adequate number of appropriate healthcare providers for the need that that population represents? I'm sorry, that was a long-winded question, but I think you know what I mean.
I think I do know what you mean, and it's a good question. I will say that we do have primary care physicians for all of our members. So we do have that. I think that, there are challenges in our community with the aging of our primary care providers, as well as other physicians. And so I think, there'll be bigger challenges down the road. I know it's hard for the community clinics to be able to afford to keep physicians on their panels when they have Kaiser and other for-profits in the area that can pay more. So I think, there are challenges. I also think from a specialty care perspective, there are some areas where there might be more opportunity. So one of the objectives we have as a health plan this year is to take a deeper dive into looking at the providers in our community and access and availability. And I will say that it's one of the areas that the regulators do monitor. So we have to do reporting on this and sort of get the blessing, or the acceptance of the regulators. So we're meeting their expectations, but I still think that there's opportunity for improvement in that area, and particularly in some areas of weakness.
Is your ability to attract providers a function of the capitation rate and the fee-for-service rate that you mentioned earlier?
Certainly that affects things, but I think it's even broader than our health plan. I think it also has to do with the providers available in the community.
Meaning there's just a finite number of folks to serve the demand that we've got.
Certain specialties that, there are just a limited number in the community as well. So,
if I were just to ask you as an elevator question, so are the rates that we're now paying in terms of capitation and fee for service adequate to attract and retain providers? What would you tell me?
Well, with California is not known for their high Medi-Cal rates paid to providers.
That was exceptionally artfully said. Thank you.
So, so it is a challenge because, again, the capitation that we get assumes that we are paying something close to those Medi-Cal rates and not paying sort of astronomical rates, commercial rates. So, it's a negotiation.
Got it. Ms. Rosas, at Valley Health Plan, any thoughts on the same subject of the ability to attract providers to serve our Medi-Cal population in particular?
No, I would echo what Christine said. I mean, it is a challenge, given, we do have aging providers. It is obviously, it goes without saying, one of the most expensive, if not the most expensive place to live in the country. It's all very challenging. But I think a main focus for Valley Health Plan is to continue to grow our network. And there's numerous ways to do that, and that's what we're pursuing. So I think we're all on the same page on that piece of it. It's a challenge.
All right. Anything else, Ms. Tomkala? Your team?
Not for me.
No? All right. Motion to receive the report, Supervisor Ellenberg?
So moved. I want to just also add my thanks for this report. It's very helpful to hear both together.
Thank you. Thank you. Without objection and hearing none, report has been received. Thank you very much. And it happens to be 3:01, which means we can move to the next item, which is item number 7. And before we have a staff presentation on this, what I wanted to do was revisit some of the history on the item, express a concern, and then give staff the opportunity, which I think they're prepared to respond to the concern that I'm going to articulate. The history, Supervisor Ellenberg, on this item is both just to provide the context on the item before we get to the nub of it, but also because much of the history actually predates your arrival, and I just want to make sure I had a chance to share that with you as a colleague. Forgive me if it's a little anecdotal to begin, but in 2014, I happened to be at a holiday party in my district, and I was asked a question by a member of the public who said, hey, why is it that here in Santa Clara County, largest county in Northern California, one of the 20 largest counties out of 3,000 in the country, certainly one of the most prosperous in the country, why is it that we don't have any secure hospital beds in the mental health arena for young people, adolescents who are at risk of doing harm to themselves and conceivably harm to others? And I, being uninformed at the time, said, well, that doesn't sound right to me, and I was assured, no, that was in fact the case. So I came back and worked with county staff and was in fact informed, that's true, we don't. And so the question was, where do those literally hundreds and hundreds and hundreds of kids go every year? And the answer is they get shipped out of county to remote locations. Sacramento County, Sonoma, San Francisco, I think the closest at the time was in San Mateo County, but with a very limited number of beds. And that presented a whole host of concerns. The hardship on the family, obviously, separation from friends and family who could provide a support network, separation from the mental health provider, the person actually providing the services. And while it's only speculative on my part, I have always worried that the fact that folks who had to be separated from their kids would be reluctant to access that care if they had to be separated from their kids, and kids might not be getting care that they desperately needed if they were at that point on the continuum of care. So we had a newly arrived director of behavioral health services, Tony Tullies, and we spent the year 2015 working in my office and with her office and sort of establishing both the need and the potential demand for such beds if we could create a facility to accommodate those young people. And along the way, we discovered that Supervisor Chavez shared the concern, and so she became a part of the conversation as well. And she and I actually met with some community folks together from time to time. And that took a year. That was 2015. Then in 2016, in an effort to create such a facility, the staff said, well, we need to do an RFP because that's what the rules say we need to do, even though we had some folks out there at Stanford and El Camino and Kaiser who said, gee, can't we do this collaboratively? And the answer was, yes, we can do it collaboratively, but we have to do it through an RFP. So we did the RFP, and that took a year and produced no acceptable respondent to the request for proposals. So 2 years had gone by. In 2017, given the failure of the RFP to produce an acceptable proposal, we continued to work collaboratively, see if we could get to yes, had some very good conversations, had a meeting where folks from Stanford, El Camino, and Kaiser and VMC were all present, and Dr. Smith, thank you again, sort of leaned in and said, you know, it appears to me that if we can get everybody to partner, the solution here is most likely that we actually have a facility on our VMC campus or as part of our health and hospital system, and that would get us to yes. But that meant then that 3 years had gone by. So then we spent time and energy thinking about what that might look like, and so a feasibility plan was prepared and brought to our full board in October of 2018, at which time the entire board, all 5 members, expressed their strong support for the effort, which was, in my view, a red letter day, but that meant that 4 years had gone by from the beginning of the conversation. Now, I have a 2-page document that I'm going to hand out. Send a bunch of copies down that way. Thank you. I'm going to send a bunch of copies down that way. And what these 2-page documents contain are on top where it says new inpatient mental health schedule. I think we've got some copies out in the audience that we've spread around as well. If you take a look at that first page and go all the way down to the bottom line, literally and figuratively, activation, which means when does this thing start? This is from documents we received at our October 16th meeting in 2018. And the activation date, the start date, the open date, as you can see down there in the bottom line, is October of 2023. That date is confirmed if you look on the chart by the little arrow over in the right-hand corner, which is also October 2023. You can then imagine how disconcerted my office and I were to receive the staff report for this meeting a few days ago, and that's the overall timeline showing us that construction was anticipated, if you look all the way to the right, to result in an opening by the end of 2025, meaning that after the past year of discussion on this process, that according to this chart, we had managed to lose 2 years in the process. Now, that would have been disconcerting under any set of circumstances, but over the course of the past year, on 4 separate occasions in my office to make sure we were staying on track, Dr. Smith was kind enough to come with some of his senior professionals in the field in May, in June, in August, and in October. And in each of those occasions, my staff and I asked, are we still on track for 2023 with the expectation that we would have a site and a preliminary design in January of this year? And on each of those 4 occasions, the answer was, yes, we are. That would have been disconcerting enough, but we went back and looked at the transcript from the October 2018 meeting, and at that time, Supervisor Yeager leaned in to say, and I'm quoting directly here, the 5 to 6 year time period is that best case. Worst case, I think all of us, said Supervisor Yeager, I think all of us hope that we can get it in as soon as possible. Dr. Smith replied, you're going to try and pin me down, huh? I would say 6 years would be worst case. I would say 6 years would be worst case. 5 years is a C+, 4 years is a B+. If we get faster than that, everybody in facilities gets a raise. Doesn't appear to be a risk with the way things are going, I might just say. So if, in fact, December 2025 is the date, that would be 1 year after what we were told was the worst case scenario. It would be 2 years later than what we were told was the expected date of completion. I've been back on the board for 7 years. There have been a lot of opportunities for me to say thank you to people for good work, and I hope I have done that often enough. But I got to tell you, I have never been as disappointed as I am today. Never in these past 7 years. And I was going to say that, you know, I wanted to make it clear this wasn't personal, but in some respects it's very personal. Because I've got kids in my hometown who are killing themselves. I've got kids who went to the same high school I did who are dying. And that's true not only in my hometown, it's true in virtually every city in my district and virtually every city in this county. We got kids who are taking their own lives and they can't wait. And our board and the people we represent have been very patient, albeit persistent, went through the process we were asked to go through, got a commitment, And now, literally, like that, another 2 years has disappeared, if we can even count on that current timeline, Dr. Smith. So I want to make the case today that we got to find a way to fix that, and that the fix has to be real. I'm not just talking about issuing a new piece of paper with a different date on it. And that once that fix is real, we have to be on it day after day, week after week, month after month to make sure that any commitment that is made is real and delivered. And so for me, what that means is that at our next meeting on February the 19th, that we have a new timeline that everybody on the county team, from the CEO down, can commit to, and that people are serious about what those dates are. And my hope and expectation is that there's still some way to get to the fall of 2023 and deliver on the promise. I'm going to ask that that be the first item on our agenda, February the 19th. If we have to move other items to make sure there's adequate time so it doesn't get rushed or squeezed, then that's what I will do as chair of the committee. I will then place this item as the first item of business on every single agenda until we're all at the opening. From now until the last meeting that I serve on as chair of this committee. And I will ask at every one of those meetings, what's the date for the plans? What's the date for the groundbreaking? And what's the date for the opening? Those three questions. And I'm hoping that come hell or high water, those three dates stay the same from start to finish. I understand there are intervening events, but to lose 2 years just because is unacceptable. I also would like to ask the county exec if we can identify a project manager on this project so that we know who we can and should go to on a day-to-day basis to say, how are we doing? Are we on it? You know, I have no doubt that, Dr. Smith, of your commitment to this project, but you got a big organization to run. Ms. Tullies, thank you for your help. I got no doubt of your commitment to this project, but you have other responsibilities. Mr. Lorenz, I have no doubt of your commitment to this project, but you've got, I used to say, a hospital to run, and now I have to say 3, not to mention all the ancillary functions, the clinics, and so on. So I'd like to be able to say to anyone who asks, let me call a project manager who's on this and wakes up every single day saying, what are we going to do to move this project forward? I also, given the fact that I can no longer feel confident in the assurances that have been provided, need to identify some way to provide project oversight. So I'm going to work with the county counsel's office and with our management audit team to see what does it take to bring in the expertise to provide that monitoring and oversight on a regular basis so that I've got somebody independent I can go to who has the expertise to say, yep, it's still really happening on schedule, or no, there's been slippage. And Mr. Press, I'm looking down at your end of the dais because I'm going to come to you and your colleagues and ask you for some help in that. I've said all I've got to say, but it's, as I say, I don't think I've ever been as disappointed as I am sitting right here right now in the progress or lack of same on an item that's received a 5-0 vote, has broad-based community support, and that was run through a process that took 4 years before the board gave its blessing. Dr. Smith, I see your light is on. If you'd like me to go to you first rather than to your team, happy to do that. What can we do?
Yes. I would like to address the schedule issue and give you some modifications of the timeline that you pointed out. I think the timelines that are listed on the PowerPoint from staff are overly generous with timing, so I'm going to commit to the committee that we will provide all resources and attention needed to do the following. So on your schematic, please look at, or on your timeline, look under schematic design. We don't need 6 months to do that. We can do that in 3 months. Schematic design was extended because there was the debate about how many sites on the campus were appropriate. We're looking at a couple of sites, actually 3 sites. We should get funding reports or financial reports about those 3 sites, but I'm quite confident at this point that the only site that will be viable will be the Donlow Pavilion with a flyover to the hospital, so we don't need 6 months to think about it. That means the design development time period can also be reduced. That will be 3 months. The construction documents can be done in 4 months. OSHPD review is the thing that's outside of our control to some extent, but for this type of project, I think we can push them down to 6 months, and construction should be able to be done in 20 months. So if you add that all up, that gets us done before October 23, not 23rd, October 2023. And I will have my office keeping close tabs on making sure that that timeline is either complied with or exceeded. And I'm happy to have it reported back to the subcommittee on a regular basis, and apologize for the miscommunication that occurred, because obviously it was not appropriate at all to suggest over the period of a month that the timeline had changed by 2 years. That was a failure in communication on our part. And you will, I'm sure, ask staff whether these are real numbers, and they will say yes, because they're viable numbers, and so that will be that.
Thank you for that, both. Thank you for the comments, and thank you for the commitment and willingness to get us back on track. Is there a presentation your staff would like to make now in terms of the proposal and a revised timeline, or no?
Actually, I don't know that they need to make a presentation. Maybe I'll just make the presentation. So let's go to, I already just went over, let's go to page 4 of the report. This is what's happened so far. It gives the indications of the user groups, the workflows. We're past the end of December. Like I said, right now we're looking at finances. Next page, we can skip that because that's basically an analysis of the square footage, which is not finalized, so that's really just a preliminary number or preliminary scan. Page 6 gives you our selection criteria for the site. I won't go over them in detail. Go to the next page, page 7. The sites are numbered in sort of a funny way, but you can ignore them. The one that will work, in my opinion, is site 4/5, which is taking down the Donlow Pavilion, the IMR, converting the logistics center and putting a flyover, which you can't really see, between what looks like logistics center now and west wing of the hospital. Also, connection between the Donlow area and the site 4, so that we can have a direct connection. And then the next page, page 8, I've already told you is modified. And page 9 was a discussion of some of the stakeholder meetings, which we'll have to change around to fit the schedule that I just told you of. So the real key message is we're committed to do whatever it takes to make sure it gets done in October or by October of 23. We're going to do a fairly superficial analysis of the cost of the various sites. I'm quite confident that the cost of site 4 or 5 will be the least expensive and most operationally desirable. And we will report back next month.
Thank you. As I say, that item will be the first item on the agenda next month. It will then be the first item on the agenda for every subsequent meeting. We'll spend as much time as it takes at the next meeting to make sure that we have a thorough discussion of the revised timeline and to-do list when the time comes. So if that means we have items that we have to defer to subsequent board committee meetings, then regrettably that will be the case. Dr. Smith, I don't need to ask you today to share your thoughts on project management for a project of this scope and complexity, but I do think it would be helpful if you'd share some thoughts on that at the next meeting, and I'm going to ask you if you could please plan to do that.
Sure.
And then additionally, as I mentioned, I'll be working with and through the County Counsel's office and the Management Audit Office to talk about possible oversight opportunities. I will share thoughts and initial impressions with you, Dr. Smith, along the way, so that that's not a surprise when we come to the meeting on the 19th. And, you know, I would, it may sound odd since I'm talking about independent oversight, but I'd value your thinking about what might constitute a good working model that would provide that independent oversight while still acknowledging the fact that the county staff is going to be responsible for moving the project forward. Okay.
We'll share that.
Do we have any cards from members of the public before I go to Supervisor Ellenberg, see if she's got comments or questions? Supervisor Ellenberg.
Thank you. It looks like you've got all of the process covered and are on top of that, so I don't have much more to add on that aspect of the timing, other than to note that I absolutely share your sense of urgency. I trust that this will be the priority that it was described today. I want to note also that this is, along with the rest of VMC, in my district, and want to ask a couple of questions, particularly with regard to slide 9, the stakeholder engagement process. Can you talk a little bit more about the different types of meetings that are planned, what stakeholders are being reached out to, how those discussions will inform the design? And I want to make a specific request, if they're not included already, for the residents who are living near VMC to be able to engage in this process and provide some input, whether or not they are the type of stakeholders that you would think would particularly have an interest in a mental and behavioral health facility.
I think I probably should turn that over to Tony and Paul. Maybe, Paul, you can start with it. But, you know, since slide 9 does have the wrong dates on it, We'll have
I'm
to,
concerned more about the content and how the outreach is done and who the stakeholders are.
Right.
For purposes of this question, as
Yep.
opposed to the dates.
that's, okay. Go ahead, Paul.
Thank you, Jeff. Supervisors. So we've engaged a number of different stakeholder groups. The first one really is related to our partner agencies, Kaiser, El Camino, Stanford, Lucy Packard, and many of the local organizations that serve this population, and working with Tony Toles and his team and her team. So those stakeholder groups have been initiated. We've had several meetings. We'll continue to have those types of meetings with our partner agencies.
Can I quickly interrupt? Those are all professionals. Do you have users, families with lived experience, other direct use stakeholders?
So those are service organizations, including NAMI and so forth. We will, as you would note here, is that we will have patient and family work groups and forums to provide them an update and receive input relative to not only the types of services that we'll be offering, but how the patient flow and coordination of care will occur relative to these facilities. And as you can see, we will start those immediately and continue on through the course of this project.
And excuse the interruption, Mr. Lorenz and Dr. Smith, but to your question, Supervisor, to give staff credit where credit's due, the part of the reason the project is, as I'm going to describe it, as complex as it is today is in part because many of the folks you just asked about were in fact involved or engaged as stakeholders in earlier conversations and were given the opportunity, which they made very good use of, to articulate a wider range of needs that the project is. And you know, that's one where I have to say both Dr. Smith and Mr. Lorenz and Ms. Tully's all were sort of mindful of the fact that they need to be early. And doesn't mean that's ended, doesn't mean it shouldn't continue as you're hearing from Mr. Lorenz, but I did want to indicate it's not as if we're starting from scratch on that by any stretch.
Thank you,
I
Supervisor.
should also jump into, since we are crossing a change in supervisorial representation, we will also reach out to your office to find out if there's somebody else that you think that we should get involved that we haven't thought of or that didn't get involved, because obviously there will be different groups that maybe you think of that Supervisor Yeager didn't think of.
Thank you. There is a specific group that I have in mind and want to recognize, since the opportunity is coming up now, and thank publicly Paul Lorenz for coming to this meeting with neighbors and bringing along a number of your senior staff members to address other questions around mental and behavioral health and homelessness, and concerns about people coming and going from VMC. They will no doubt have questions about how this plays into those pre-existing concerns as well.
Yes. And we will engage our community, particularly our neighbors around the hospital, to ensure that they're informed.
Thank you very much, and my staff can help connect and
Yes.
make that happen. Thank you. All right, I guess more to come next month. Thank you all very much.
Great. Dr. Smith, Mr. Lorenz, Ms. Tully, anything else you'd like to add at this point before we simply indicate that we have received the report and provided direction as indicated?
Not at this time.
Then, Dr. Smith, no?
I've said enough.
Thank you. No, thank you. I was happy to hear it. Then, Ms. Ellenberg, if you're prepared to move that we receive the report and provide direction as indicated.
So moved.
We have a motion by Ellenberg and a second by Simidian. And let me just look to the clerk's office. As we've indicated earlier, we're asking somewhat unusually that the minutes for this item on this meeting be verbatim so that we get a transcript of the comments made by all parties. Okay, and then without objection and hearing none, so ordered. That takes us to item number 8, which is the recommendations relating to emerging issues regarding the County of Santa Clara's health system. And
Yes.
thank you to all who came down, but apparently will be back with us again in the future. So thank you.
Yes, good afternoon, Mr. Chair and Supervisor. Just very briefly, I have in my report, the written report, the 3 concrete actions that you asked of us, Mr. Chair Simitian. And so we indicated things that we're already doing, taking in place right now to expand coverage for residents in our community. If you have any questions related to those, I'll be happy to answer those as well. To the point, I believe, Supervisor Ellenberg, you were asking about the ACEs. We have the partnership that I mentioned with the key stakeholders, and we are collaborating with them to submit one single application for a county, given all the work that we've done to expand not only the physical and the developmental screenings in our community, but more importantly also the behavioral health screenings. So that's actually a very good news for us to be able to not only highlight the work that we're already doing, but then also to go beyond just raising awareness within the physician practices of how important it is to identify the adverse childhood experiences and how that has direct health effects not only early in life, but also later in life. So we could report back in terms of that particular initiative as we get more information.
I appreciate that, and I really want to commend the collaborative nature of the application. I don't know how many counties are going to have the wherewithal and the relationships to be able to present a unified request for funding, and I think that I certainly hope that will look very favorably on Santa Clara County, and that we'll be able to do a lot of good work with that funding. Thank you.
And thank you. The other piece I wanted to highlight is it's been referenced, and I think Bert Margolin will have a little bit of an update in terms of some of the state legislative updates, but I think one of the things that we're keeping our radar screen as the waiver expires, and potentially there may not be supplemental funding for some of these projects and initiatives that are driving us to value and performance-based. I've indicated already to our county executive that if we don't have successful negotiations with our managed care plans, what that means for us is that we potentially could have a budget gap at Valley Medical Center, and obviously we'll continuously keep Dr. Smith informed about those things, because the state is directing us to be aggressive in our negotiations with the managed care plans. And I know we want to be collaborative. I think that's in the spirit of the County of Santa Clara. But yet, on the other hand, of course, we need to make sure that we continue to provide the services and the programs that we started here in Valley Medical Center, inclusive of our community partners in terms of community clinics like whole person care, for example. The other update we have is the unit-based teams. This is just a gift that keeps on giving. We have 15 new teams. Amy, Carta, and the whole team deserve, again, recognition for not only having another cohort of broad project teams that are working in a variety of different settings. And so we give you an update on those, and it's just wonderful news in terms of our change process. That concludes my report.
Supervisor Ellenberg, questions?
Just a really quick comment on some of the things that are included both in this report and in the report on consent. I want to appreciate the report on the jail pilot and the off agenda on STD screening at booking, and just looking forward to continued collaborative effort across the health system in response to my referral on that. So thank you.
And Mr. Santiago, candidly, I've been so focused on the previous item these last couple of days, I have not had a chance to give your report the time that I would like to, and that I feel sure you'd like me to. So I'm going to take the time to give it a more careful look and circle back. Might do that off agenda, might do that in bringing back some piece of it. But I very much appreciate your response to the request about coverage expansion. Looking to my staff, who's here in the chambers today, we'll follow up with you on that. Right. For me, that's a priority for this year, which is as good a job as we've done already. How can we cover even more people? Because to me, that's the ultimate solution to a very challenging problem, but harder and harder to do as we have more and more folks in place. All right. Then who's up next? We do have a couple of cards. I have one from Scott Largent on 8D, and then one from Robert Sapien on 8E. Gentlemen, would you like to come up now, or would you like to wait until we get to that point in the presentation? Thank you. Mr. Largent, would you like to come up now? Are we still in the room? Well, apparently the answer, there he is. Thank you. Sure. No, that's all right. We have a lot of moving parts under item number 8, as you know, and if you'd like to offer your comments now, we are going to go to the Public Health Officer, the VMC Chief Executive Officer, and then the Director of Behavioral Health Services, but feel free to share your comments now if you like.
Okay, great. Appreciate it, Joe. Thank you. Thank you. The item I come up is normally the behavioral health one, so 8D is what I'm kind of chiming in about. When I was downtown one time, I don't know if you remember this, Susan, I had ran into you on 3rd Street kind of walking by. I normally don't run into politicians down there. Normally everybody's too terrified to be downtown, so I do give you a thumbs up that you were actually out and about. The gentleman that I was walking with, the mentally ill homeless man, I have put a video up online. He went through the foster care system, the group home system. He has a severe meth addiction. I wrote this thing on here, and I know I kind of have some colorful language, but he's convulsing and he's falling into a wall near the light rail thing, and he can't stop his body from, it's the meth that's doing this. So I wrote this. I said, this man needs help. He is nice, he is kind, he has a meth problem. Why won't we help him? Why do we allow this man to smoke meth 24/7, 365 days a year like it's a cigarette? We allow him to chase the dragon. We give him a get-out-of-jail-free card. We excessively bill him out for services that are not working, okay? In San Jose, Santa Clara County, we leave people like this to poison their bodies and pretty much slowly kill themselves on our city streets. Children, families, and the elderly walk past hundreds of people just like this man that are slowly dying right in front of them on the streets of San Jose. Feces, needles, glass pipes, urine, trash, chemicals, garbage line the sidewalks like a bad zombie movie in downtown San Jose. We turn a blind eye to people that are suffering in the wealthiest city in America. I am ashamed of humanity and my fellow men and women in Silicon Valley. People should be mad and upset that taxpayers have already pretty much forked out the dough to not have this happen. I'm just amazed that we allow this to happen. Thank you.
Thank you. Next report is 8B from the Public Health Officer.
Good afternoon, Supervisors. Dr. Sarah Cody, County Health Officer. I thought I would mostly focus on giving you an update on the novel coronavirus since it's been much in the news and we're spending quite a bit of time working on it. So just a brief thumbnail, as you probably remember from the news, it's a novel or new virus that was first discovered just the end of last year in Wuhan City, a province in the middle of China. And the initial cases all had some sort of contact with an outdoor market. And this is not unusual for a coronavirus. Usually it's a virus that you might find in an animal reservoir and then it hops over to humans. That was the case with SARS and MERS, viruses of our past. And then the question is, will it spread person to person? So what we now know is that there has been some person-to-person spread. It's still a question about how transmissible it is. We still don't know just how severe it will generally be, although there have been reports of some severe cases and deaths. We also know that as of now, there have been cases reported from a number of other countries, including Taiwan, Japan, South Korea, and Thailand, and then yesterday the first case was reported in the U.S. In Washington State. So this is, I would say that having the public health system having responded to a number of viruses like these, we're just doing our jobs. So what that means is we set up a surveillance system, notified providers, we doing a lot of that work today, actually, so that anyone who meets a particular case definition, sort of a worrisome exposure and worrisome symptoms, they get reported to us. We coordinate testing, which is currently only done at the CDC. And that's really that in a nutshell. So it's a lot of getting information out to providers, and we're trying to surge our staffing because we need help with phone calls. People have a lot of questions because it's early. We're getting, reports of should we worry about this person, et cetera, et cetera, et cetera, which we're responding to. So just in sum, this is something new. The information's changing by the hour. We just have one case in the U.S. It's in Washington State. There's very little question in my mind that we will have cases, and particularly in California, and perhaps in the Bay Area and perhaps in Santa Clara County, and we'll continue to share information as we have it, and I'm happy to answer any questions.
Thank you for the report. Supervisor Ellenberg, comments or questions? None, but thank you. Mm-hmm. And please do keep us posted as we go forward. I'm thinking about prior conversations. As a layperson, it's frankly difficult to thread the needle when it comes to being thoughtful and prepared as opposed to overreacting to something. And so anything you can do to help us find just that right spot would be helpful.
Right. I guess what I would tell you as the public health officer speaking to the public of lay people, this is not a health threat to us. So this is something, read the news, be aware, but don't be worried. If you're going to travel to China, particularly to Wuhan, that's different. You need to take some precautions. But absent that, there's really no increased risk to the general public.
Is that something that could change 3 months or 6 months from now?
Well, we are just, again, still learning about the virus and how the virus behaves. And one of the challenges with this, as with SARS, as with MERS and these other viruses, is that they're originating in another corner of the globe. So we really depend on getting information about what's happening in that corner of the globe and then having it shared with partners. And I would say that sharing has improved over time. So that's good. And I will continue to keep the board informed.
Thank you. That takes us to 8C, which is the report from Mr. Lorenz, the CEO at the Valley Medical Center. Yes?
Thank you, Supervisor. I'll be brief on two topics. First of all, around mammography services at Valley Medical Center. Over the past several years, we've been focusing on trying to improve accessibility to those services. I'm pleased to share with you that at Valley Medical Center, at all of our health centers, appointments for mammography screening services are less than 10 days. And at many of our clinics, we do have same-day walk-in appointments available for the public and for our patients. At Valley Medical Center, the diagnostic mammography services, wait times are less than 7 days, and we also have same-day appointments for breast ultrasounds. So that is a significant improvement over the past several years in terms of our ability to provide these services to the public. Wait times are monitored on a daily basis. A lot of that is attributed to our ability to utilize our HealthLink system. So we have a daily dashboard that monitors our services for women around mammography. I also want to share with you that the department, Valley Medical Center, is submitting on March 15th an accreditation application with the American College of Radiology to become a breast center of excellence. So we obviously looking forward to further improve our services and the quality of care we provide the public. We also will be, and this is something that you are familiar with, Supervisor Simidian, looking to transition our technology to 3D. And that is something that we're looking to do first at Valley Medical Center later this year, and then we'll roll that out to our facilities. We are also working very closely with the 3 hospitals together to improve access to mammography services geographically for our communities. And that collaboration will continue throughout the year, and I think we'll see continued progress and improvement in those areas. The other item that I wanted to just briefly mention, John Mills is here. Obviously, this committee has been very interested in our progress relative to staff stabilization. All indications are, as John Mills had reported, recruitments are in place, certification certified lists are being generated for the managers, and hopefully within the next 30 to 45 days, job offers will have been made, and we will have the vast majority, if not, with the exception of those in classified positions, secured in their positions going forward beyond March 1st. John Mills, as I've said, is here and available to answer any specific questions that you may have on that topic.
Thank you very much. Supervisor?
Thank you. Paul, your comment that hopefully they'll have them in 30 to 45 days makes me nervous. I would like something more definitive and declarative as opposed to hopeful. These are folks that have been waiting a long time.
But let me defer to John Mills, and he can speak to where we're at.
Yes, thank you, Paul, and thank you, Supervisor Ellenberg. Yes, I would be more certain than Paul characterized it. Just as a very brief overview of the items that I had attached to this item on the committee's agenda. We had provided two reports. One report that we provided last week, shortly after the agenda was published, that was our current data as of January 15th, and then we provided an updated report that was current data as of yesterday. And my intention in providing those two reports was twofold. A, to give the committee the most up-to-date information that we could in written form in advance of the committee's meeting, and B, to show the committee how the data is trending in the right direction and how even in the short span of a few days with a holiday weekend intervening, that a lot of lists are being referred. Because we are at that point in our process now where recruitments for job classifications that have provisional employees in them, all of the posting bulletins have closed. We had our final written exam this past Saturday, and I believe in the report that you received yesterday, we referenced that there were 43 individuals whose job classifications were part of recruitments that were still in progress. That means either they've just taken the exam or the exam is being scored.
Right, John, I'm going to interrupt you and stop you there because I have no doubt that you're working hard and quickly at this. I want to share a couple of comments that I just want to be in your head as you're going forward with this.
Please.
And also want to turn to Dr. Smith again because I still haven't seen a plan for communication improvements with employees. You have reassured me a few times that I'll have that. I still don't have it, and really would like not only for myself to see, but to be able to convey to employees that that there is a specific plan. We've taken steps to improve communication, particularly with regard to unclassified and provisional staff, given to Paul's comment again that all of the provisional appointments expire next month. So I would like to see, today is Wednesday, by the beginning of next week, by Monday, a communication plan. How are you reaching out to the folks that are still unclassified and provisional so that they don't have another 18 months of worrying what is the future for their jobs? I do appreciate and saw that the number went down from 97 to 43 employees in recruitment. That's great. What are the close dates for these recruitments? And can you tell me when you expect to have for all of the hiring managers to have their lists? And I'm asking because I'm concerned about the time pressure that we're putting on the departments to complete those recruitments. And again, the uncertainty that that's leaving for so many employees in this process.
John, why don't you talk about the communication plan, and then I'll lean in. Go ahead.
Yes, no, and thank you for the question, Supervisor. In terms of the question about when the recruitments will close, so all of the bulletins have closed, and actually the 43 number as of today is now down to, I think, 37, because a few more were referred this morning.
Okay.
So those remaining 37 employees, the job classifications that they're in, those eligible lists will be referred by the end of next week.
Okay.
So at that point, all of the provisional employees will have had their recruitments referred to departments. And we are in the phase now of this process where we are turning our full focus to supporting the hiring managers at the hospitals with the interview processes. Because once the lists are referred, the provisional employees also get a notice that they contact the department to schedule their interviews. So as you can imagine, the volume of interviews is quite high right now.
Right, and it sounds like there is a communication plan. I just haven't seen it yet. So if you could share that with me so that I can reassure folks or point them to what resources are available, that would be great.
Yes, well, I mean, absolutely. What I might do in the short term, specifically as it relates to if you are getting any questions from these remaining provisional employees, we have been producing a newsletter for the employees at O'Connor and St. Louis that has, the contact information for the ESA staff who are on site, that has the, well, now they're all closed, but that had the listing of the open bulletins.
That's great news. That's something that we had talked about, and I just haven't been told or haven't seen it. So we have a communication piece here as well. Close the loop with me so that I know and can promote the work that is being done.
Absolutely. I would be happy to share that with you. And then related to specifically the unclassified employees who are now on a longer time frame relative to when their unclassified positions will expire.
Right.
That is the sort of communications and transition plan that we are working on in response to your board referral from, I believe it was December 10th, with the understanding that there would be a report back on that preliminarily at the February HHC meeting and then the second board meeting in February, since they're on a different timeline than the March 1st timeline.
Right. So let me just make a general comment about that too, and we will discuss it next month with the response to that referral. Again, paying attention, really close attention to language. I wouldn't consider that we have really resolved 100% of the employee issues as a result of the acquisition, as was stated in the report. I believe perhaps that statement was with regard to the tracking of some particular requests, but again, there are still folks whose reclassification is still in process, who are unclassified related to the acquisition, and there are still hundreds of employees in various stages of the recruitment and hiring process. They don't feel that their questions have all been resolved, so that's just a caveat on language. I really do appreciate the continued effort to complete the recruitments under significant time pressure, and just hope going forward that we really focus on a strong customer-focused approach that can be employed in working with the employees and hiring managers in these last weeks. And I look forward to discussing the referral response next month in the next phase of this work. Thanks. And you don't have
Yeah, he'll send it to you. And, I also wanted to encourage your office whenever they contact somebody as they're communicating with ESA, to copy me on an email. I have asked
glad to do that.
ESA to give me actually the list of names, so I do have the names of the 37 people that we were talking about and all of the others. I obviously don't want to announce it in public because it's personnel information, but feel free to contact or copy me on it so that John and I both have the same information.
Thank you. We'll do that.
Absolutely.
Thanks,
Always
John.
happy to help. Thank you.
All right, thank you. Mr. Lorenz, anything else at this time?
Nothing at this time.
Thank you. And am I correct in understanding that we're going to take the EMS matter up under 8E? Is that the plan? That is correct. Okay, Great. Then let's go on to the next item, which is, before we do, here's what we're going to do. There are no secrets here, notwithstanding the whispered conversation, just so you know. But Supervisor Ellenberg, as she had previously indicated, has to step away at 4. So I'm going to ask her for a motion to receive the various reports under item 8.
So moved.
I will second. The reports will be deemed received for purposes of today's committee meeting, but I will be sitting right here to hear the rest of the reports. And I know that Supervisor Ellenberg has her staff here as well, who is going to be listening to the reports. And I know because she's going to listen to them after the fact. So don't think you're going to escape her careful scrutiny, is what I'm trying to say. Thank you,
everyone.
Supervisor.
Please excuse me.
All right. Next item takes us to item 8D, and that is the verbal report from the Director of the Behavioral Health Services Department, Ms. Tully. So that's you.
Yes, Supervisor. I'm going to be brief on this and then answer any questions that you might have. In the verbal report, I think there are 3 things, and then we can talk about the services. We did complete our 3-day external quality review last week. It was very positive. I'm expecting that we'll have very good results. Lots of comments about the diversity and the work that we're doing with consumer and family employees. Heavy-duty effort. We also yesterday held our first MHSA forum. We had almost 150 people there. Rather than have multiple stakeholder processes, we followed San Bernardino, and it was a very robust, very, very well attended, interesting day for us. Explaining the MHSA, explaining the services that we currently fund, talking about what the processes are, and then really asking for many people in the community to come up with recommendations that we'll be able to look at and then bring forward with the plan when it's completed. The next thing that's not here that I want to mention is we have been very successful in recruiting 3 fabulous new executives. Sherry Terreo, who has been our executive for the Children's System of Care, has now been promoted to a new position as the Deputy Director for the Service Delivery System. And that's a very exciting new position, and she's been in her job about a week. But I think it's going to be a great addition, not only to the department, but to the county and to the work that we do. In this particular report, we brought forward a status on all of the new intensive programs that you had asked about, and we've provided information both on the programs themselves and where the services lie, with which providers, and where we were at the beginning. This data is about the end of December. I can answer any questions you have on this, Supervisor, but I will say our report on the 28th provides very detailed information and charts on all of those intensive services, where they stand and what is underway. So I can answer now, or we can meet with you tomorrow as planned.
We'll look forward to it. Thank you. All right, and that does take us then to item 8E, and we're going to go to the CEO of the Valley Health Plan. That's what it says on my agenda. Did I get a revised agenda? And the CEO is going to say, I already did that. Okay, and then I'm going to say, that means we are ready to hear about EMS. And we do have one card from Chief Sapien, who's been very patient. Chief, would you like to hear the report first and then weigh in, or would you like to weigh in at the front end?
I'm happy to stand by.
Okay, thank you so much. Dr. Smith, would you like to be the ringmaster on this one?
Actually, I'm going to let Miguel be the ringmaster.
Okay, thank you.
Thank you. Just to go over the report, on the report we note that we did have an EMS 2022 meeting, and the minutes of that meeting are set forth in the in your packet. We also have since met, I think it was on January 10th, and had another productive meeting, and we continue to look forward to working with our partners to come up with a plan for the next round of EMS contracting. A couple other things that are in the report is we do have here that all first responders have exceeded their on-time compliance reports. And then with respect to an issue that came up last time relating to an issue that came up because of the Seventh Amendment, the good news is we had, as reported.
That's of the contract, not the Constitution, just for the record.
That's correct.
Okay.
Seventh Amendment of the contract. Yeah. I know the Constitution is quite a bit in the news these days, but we had two independent and using different methodologies looking at the response times, and Dr. Miller is here and can certainly tell us more about it, but looking at two different data sets and applying the response times, it was concluded that the response times have not changed pre versus post Seventh Amendment to the contract, and patient care was therefore not an issue in the glitch that we had. What did happen is during the negotiation of the Seventh Amendment, Rural Metro AMR made a point saying when a call is canceled, and there's a significant number of calls that do get canceled for a variety of reasons, there is a system in place that would predict when the ambulance would arrive. And the way we had done it prior to the Seventh Amendment is looked at the predicted time, and if it was going to be late, or if when the call was canceled it was late, they would get penalized, or it would be considered a late call. However, if it was going to be on time, it was ignored. And so as a way to fix that issue, they said, let's instead look at the projected time, and if it's going to be late, we get a late call, but if it's going to be on time, we get credit. The problem with the system is that the projected time is not updated in real time, and so seconds or even minutes could go by before the real time, before the update to the projected time gets put into the system, and therefore, all that is to say the provision that was agreed to in the Seventh Amendment because of technological limitations created the purported non-compliance that we saw last time.
Excuse me, is this the so-called marvelous software?
That's correct. Marvelous is used for a different purpose than for calculating the response time.
I'll just say I think it's a misnomer and let it go at that.
That the system is marvelous?
It's not very marvelous when it's measuring response times.
All right, keep rolling. I'm sorry for the interruption. I just want to make sure I was tracking you.
So we recognize that because we came to agreement on a provision that the technology, the marvelous technology, was unable to implement properly, we need to come back and have a different way to address that, and we will be doing that and coming back to this committee and reporting, and then going to the board to get, I guess, an Eighth Amendment to the contract, not the Constitution. And with that, we're happy to answer any questions.
We actually spoke. The EMS agency and Rural Metro AMR have reached consensus that we will return to the former contract methodology for determining response time, and they are in consensus with that. We will begin discussions immediately on any other open issues. So, and basically, the bottom line is it was not an apples to apples sort of comparison, trying to do a reconciliation with the current methodology. So,
We had, and Dr. Miller, you may want to weigh in as well, or Ms. Marquez, Ms. Lowther, we had a not very satisfying conversation a few months back where it was frankly hard to get a clear understanding or explanation of what the technological challenges were. I've got two questions for you. The first one is, are you all three convinced that you understand, and I don't mean that in anything other than the most respectful of ways, but it was a pretty jumbled conversation, that you understand the technological issues well enough that you can feel confident in telling our board and this committee that the response times haven't changed and that there hasn't been an adverse result? Yes? No?
Yes. Yes.
Yes, and we had a number of meetings, including with County Council in my office and EMS and others, and we really did vet this closely. We had additional data come through, and we do feel comfortable and confident in so reporting.
And one of the issues that was raised previously was the concern that, as I recall, we're essentially obliged to rely on the self-monitoring, self-reporting of the contractor, Rural Metro AMR, because they hold access to the system. Am I remembering that right? And feel free to tell me I'm remembering it wrong if I'm remembering it
No,
wrong.
you are correct. They do hold the license to Marvelous, and they were submitting the data. And prior to the Seventh Amendment, before we got into all these canceled calls and the time stops, whatever, it was working very well, the data, because we do random reconciliations. But this was, Marvelous was not programmed to do this.
And forgive me if I've asked this previously, but just refresh my memory. When you say random reconciliations, does that mean we have some ability to essentially audit their process?
Yes.
We have total ability to do that.
Yeah.
Let me clarify maybe just a little bit. The calculations provided through the amendment was a methodology created by the contractor. And the data provided in that methodology was theirs. We have command of the data of the system. And to give you sort of a basis for our observations and conclusions that the performance of the EMS system, independent of contract compliance, is unchanged, is using the raw data from computer-assisted dispatching, CAD. That's the ground truth. That data is generated by button pushes and by voice communications by the vehicles to county communications, and that tells us the time frames for activities of the ambulances. For example, the response
Excuse the
interval.
interruption. Let me just. How often do we audit this information or take advantage of the opportunity to access it for a review?
That can be done in detail at any time, really.
Excuse the interruption again.
Yes.
That was
Monthly.
thank you.
There you go.
Now that's why we got three people here. Is one of them will understand the question I'm asking. So the answer is that at least once a month, typically, we check in to make sure that what we're being told is in fact the ground truth. Yes. Got it. All right. I'm good unless you've got anything else you want to share.
That's good.
All right. Then let's go to Chief Sapien. And thank you again, Chief, for your patience.
Thank you very much for the opportunity to speak. Just following up on the two questions I asked at last month's meeting, I did provide them in writing on December 11th through the clerk. The first one just has to do with one of the provisions in the agreement, the Seventh Amendment, had to do with, I'll just read it just to make it simple. Arrival on the scene of a county-authorized ALS first responder, county-authorized quick response vehicle for Sunnyvale or any other authorized jurisdiction in the county, or county authorized ALS ambulance shall stop the first responder time clock. That provision of the agreement has not been put into place, and so we have no idea about ambulance on-scene times and whether or not we have an opportunity to stop our clock as first responders. That wasn't addressed in the staff memo, so I thought I'd follow up again. And the other part I'll just add is I'm reading this provision based on a slide from back in June or so. I don't know if that's actually in the contract or not because I haven't seen the amended agreement, but that was what we were told was going to be amended in the agreement. My second question had to do with the CAD Marvelous system and whether or not it would better serve the county to have access to that system that provides a wealth of operational information for understanding where county ambulance resources are and what their availability is. I suppose that may be moot if it's going to be taken out in terms of their reporting process in what would be, I guess, an 8th contract amendment. Maybe.
Although, excuse me, Chief, I inferred, perhaps correctly, perhaps not, that your thinking on this is that that there would be benefit more broadly in terms of the operational, shedding some light on the operation of the system from the data if we had the ability to just cart off the data and take a look at it.
As we seek to optimize our future EMS system, I think it would be very important information to have. Yeah.
Thank you. Anything else? I know I stepped on your time. I apologize.
No, I believe that's it. Thank you.
Thank you. Before you step away, let me just ask Mr. Marquez, those were questions that were asked previously. I don't think, apparently there hasn't been an ability to respond specifically to those questions. Could we ask that we get an off-agenda response? And Chief, those off-agenda responses are public documents.
Yes.
And that they be considered. I don't have a conclusion. For once today, I can say I don't have an opinion. But that they be considered in the report back on the Eighth Amendment, because if they have implications going forward, the Eighth Amendment gives us the opportunity to have those conversations. Is that, Mr. Marquez, does that work for you?
Yes, we can do that.
All right. Chief, thanks very much.
Thank you.
All right. Anything else before we consider this one heard?
No, sir.
All right. Then what better place to end than with item 8F, which is to receive the verbal report relating to federal health policy and budget landscape from Bert Margolin. And tell us something uplifting and positive, Mr. Margolin.
That'll be quite a challenge.
There you
but
go.
I'll do my best, Supervisor Smitty.
Counting on it.
So let me, in the spirit of uplifting and challenging, let me start with impeachment. As is obvious, it's brought all significant business for the moment to a stop in Washington. And even though there's a cloud of uncertainty because of impeachment, and even though it's an election year, there are a number of significant health issues pending that will be acted on in the weeks and months to come, and I want to highlight them for you and your colleagues. And they're in three categories: legal, legislative, and regulatory. And we'll start with the legal. And we'll start with the public charge rule, which was referenced earlier in the Family Health Plan report when they talked about the dip in Medi-Cal enrollments, and they were talking about factors that might have been responsible. They talked about this pending public charge rule as a factor. There is currently, it's a nationwide injunction in effect that's keeping the public charge rule from being implemented. At one point, there were multiple injunctions. Now there's simply one left, the Second Circuit. And the Trump administration is attempting to go to the Supreme Court now to get that injunction lifted. They're in the middle of that process, and we'll have to see where that goes. But for now, public charge rule is not in effect. There is this injunction. Trump administration challenging, and we'll see again how that resolves itself. We've also talked multiple times over the last several months about the Texas versus Azar case. It's now called Texas versus United States. The effort by 20 states to overturn the ACA by litigating over the individual mandate and whether or not it's unconstitutional now that the tax penalty has been taken away. We waited a long time for a ruling from the Fifth Circuit Court of Appeal. They ruled last month that, in fact, the individual mandate is unconstitutional without the tax penalty. But they did not do what the trial court judge said, which is to invalidate the entire ACA. What they said, in fact, is we think it's unconstitutional by a 2-to-1 vote, but we're not sure how much of the ACA should be allowed to survive, how much can be severable. So we're going to send this back down to the trial court and have them do what they call a finer-toothed comb, that was their exact quote, analysis to see how much can be severed and how to apply their judgment to the actual operation of the law. Attorney General Javier Becerra here in California and his allies in other states that support the ACA didn't like very much the idea of this delay, sending it back down to the trial court. They wanted to have the issue resolved once and for all at the Supreme Court level. They made an effort to get the Supreme Court to take up the case on an expedited basis, and the Supreme Court said no. So because of what the Fifth Circuit did, because the Supreme Court said no to the expedited process, we're likely not to see a decision this year, probably in the following session of the court on that ACA issue. On the legislative front, we had a budget deal in December, which has taken the key funding issues we've been tracking, the implementation of cuts in the DISH program, funding for community health centers, and it's deferred all that till May 22nd. The DISH cut's been delayed for that time period, and the funding for these other programs that are at risk have been extended for that period. So there'll be some kind of a deal in May on our DISH cut issue and on funding issues. They have strong bipartisan support, the issues we care about. There needs to be a pay for some way of offsetting the cost of the new funding, the new spending. And members of Congress are looking at either surprise billing reform or pharmacy reform as sources for the pay for, but we don't know what they're actually going to settle on. And that's several months off still.
Excuse me, Mr. Margolin.
Certainly.
Since I'm the only member left, I feel a little more comfortable being conversational with you.
Sure.
Are the pay-fors real, or is that just, I mean, do they really pay for, or is that just the device that's necessary so that and is everyone just engaging in a fiction, or are they real?
No, it's real. It's real, except the lack of reality that sometimes affects it is when they operate on a multi-year projection of what the savings are going to be. And despite the best efforts of the Congressional Budget Office to project multi-year savings, they're off sometimes. So it isn't, there are other kinds of budgetary mechanisms at the state and federal level that are kind of, as you're suggesting, not so real, kind of technical or artificial. These are real offsets. That's why these budget impasses occur, because the cuts or the savings people really battle over because they're real.
Got it. Thank you. I appreciate it.
Sure. As for the 2021 budget that we're going to be moving towards in several months, we're unlikely to have the kind of collision or clash we've had in other budget years. We have a 2-year agreement on the top line funding numbers agreed to last year that carries us into next year. So there's not going to be a resolution adopted by the Congress to set budget targets. That's already been done for 2 years. The debt ceiling that always snags these negotiations, it's also been agreed to through this year into next year. So while it's likely that we'll end up with a continuing resolution, a CR, at the end of the year, that's fairly common in an election year. Typically, you have a negotiation, then you have a CR, and then the lame duck Congress does the final budget deal. But there's a good chance this will be done in a more normal process without an era of crisis and budget and government shutdown. I do want to report on one other budget issue that you asked me about last month that was part of the budget deal, and that's the Dickey Amendment and the issue of gun violence research. And at the time, I wasn't aware enough of the history of the Dickey Amendment to answer, but I did some research since then and can now respond to your question. Dickey Amendment passed in 1996, and for the last 2 decades plus, it's stopped the CDC and other agencies from doing research on gun violence. The language of the amendment basically said that CDC and other agencies can't advocate for gun control. And even though research, one can argue, isn't advocacy, the language was vague enough to have chilled even research, and nothing occurred for a long period of time. Dickey Amendment change this last December really is the second change in 2 years. A year earlier, in 2018, the Congress made another change to the Dickey Amendment, where they explicitly stated that the original language from 20 years ago, which said you can't advocate, you can't promote, does not exclude or preclude research, that research is allowed. They clarified that in the law last year, and that's at the time, people said, well, what difference does that make? You've clarified the law, but you've given us no funding. So some people said not much of an improvement, but it did lay the groundwork for the $25 million that was agreed to in the budget deal of December 2019, which now has provided money for 2 agencies. Half goes to CDC and half to NIH, $12.5 million to each agency, to explicitly do gun violence research for the first time since the Dickey Amendment passed. So it is a big breakthrough. Some have said it's a drop in the bucket. $12.5 million per agency is not very much. Federal government spends hundreds of millions of dollars on other public health issues, doing research and analysis and investigations. But it's the beginning of a process, and it's real money, and there'll be real research being done.
And excuse me again,
Yes.
I heard CDC, the other agency that receives
The National Institutes of Health
Thank
is
you.
also going to receive $12.5 million. So that's my Dickey Amendment update.
Thank you for
requested.
that.
So other health issues that will be dealt with in the coming weeks that are sort of holdovers from last year. The first, surprise billing. We talked about this also last month. There was a deal struck on surprise billing between the Senate Finance Committee and House Energy and Commerce, and for a while people said the issue's resolved. And then House Ways and Means said, wait a second, we aren't part of this deal. We have a different approach, and now we have a new negotiation going on. The issue there basically is how much of the surprise billing dollar amount is going to be subject to an arbitration process, which is what the health providers want because there's flexibility and they can get, they believe, a higher rate, and how much is subject to a fixed regional benchmark where the dollars are locked in and the providers are worried it'll be too little money. Obviously, from the federal government perspective, the more benchmarking you have, the more savings you get, the more money that can be applied to these other funding priorities, but the providers have a different point of view, and there's a battle still going on. On drug pricing, in the middle of all this impeachment activity, there was a major event that occurred on December 12th last month. There was Nancy Pelosi got a bill passed by the House Representatives, the Elijah Cummings Lower Drug Costs Now Act, named after the late congressman. It involved months of negotiations between the Progressive Caucus and the Speaker, and the key feature here is the House wants to give Health and Human Services the authority to directly negotiate prices with drug companies. And they were battling over how many drugs per year, whether it could be 25 drugs minimum or 50 drugs minimum, and they worked out a compromise, but that's the heart of the Pelosi bill. The Senate has said, we have a different approach. We're not taking up the Pelosi bill. They want to focus on generic drugs, on capping in Medicare out-of-pocket costs. And when it comes to drug prices, they want to force drug manufacturers, if their cost rises a certain amount above inflation year over year, to issue rebates. So it's not a strict price control, but it is regulatory. There is a rebate penalty. And that's actually triggered an interesting Republican versus Republican fight in the Senate. Mitch McConnell and many of his colleagues don't like any regulation of the drug company that involves impacting prices through government action. They don't want to take that approach. And they don't like this provision. Senator Grassley has struck a deal with Senator Wyden, bipartisan deal. He wants this provision, and Grassley and McConnell have actually gone back and forth in an internal party fight over this. Unclear where it'll end up. But that issue, again, there's a lot of momentum behind drug pricing reform. Something may happen this year. So let me talk briefly about the regulatory front, the third category that I highlighted at the beginning. And the big issue there, also referred to in the Family Health Plan report, is the MFAR rule, the Medicaid Fiscal Accountability Rule that we talked about last month as well, that has the potential to impact the financing of public hospital systems in a very dramatic way. Last year, and this deals with supplemental payments and the way in which the state match is generated to draw down the federal money. California, like a lot of states, has a very complicated system for drawing down the federal match. Federal government doesn't want a complicated system. They want state dollars and real tax dollars to be put up, in their view, and for the match to be drawn down in that way. Initially, the Newsom administration wasn't sure how to react to this. The lead advocacy on this issue was largely being pursued by states like Texas and Florida that are also adversely impacted and that have a somewhat closer relationship to the Trump administration. Governor Newsom, though, a few days ago actually did an interview in the media where he talked for the first time about how serious the MFAR rule would be in terms of financing of Medicaid, billions of dollars of impact. But he also projected some degree of optimism that because Texas and Florida and other states are impacted, that in the end the Trump administration would back off. Unclear whether that'll happen or not. We'll know this spring. If they back off, very good news. If they don't back off, the state and the counties are going to have to engage in a very intense discussion about how the funding gap is filled and how Medicaid is financed. So those are the federal issues. I'm going to briefly talk, as Renee Santiago referenced earlier, about the governor's state initiatives in his budget, just very briefly. Again, CalAIM, as it was previously called, it's now Medi-Cal for a Healthier California for All. That's the new title. There's no acronym yet. At some point, hopefully, they'll develop one. There's almost $700 million of funding there for partial year funding for the new CalAIM Medi-Cal reform proposal. The problem is, because it's designed with our expiring Medicaid waiver, it's designed to replace a lot of the revenue we got through the Medicaid waiver, there's a concern on the part of public hospital systems throughout California that it will not pencil out, that the amount of money generated through this new reform initiative, which is going to be delivered through Medi-Cal managed care plans, a major change, a major shift in how the dollars are delivered, that when the counties in the end close their books, there's going to be not as much money as was previously provided through the waiver. So there's a lot of negotiating and a lot of, as Mr. Santiago suggested, intense work to be done to see whether this does pencil out and whether the governor's reform allows the counties to keep the investments that have been made and the infrastructure that's been built around whole person care and health homes to keep that infrastructure sustained and moving forward. Another item of interest to the county is the coverage proposal for undocumented older adults, 65 plus. Funding that population. Kids were done the prior year. Now the governor wants to tackle 65 plus. That'll be a big issue this year. And then another example, last item I'll reference here, certainly.
And if someone were to ask the state administration the rationale for providing this care to people 65 and up as opposed to people
55 and up or 45
or
and up.
is what? I mean,
well, I think it's probably a budgetary issue in that this is going to cost $350 million a year when it's fully implemented. Less than that first year partial, but ultimately over $350 million a year. And if you're looking at healthcare needs increase. The older a person is typically, and I assume the administration's rationale is undocumented adults 65 plus have higher healthcare needs on average than 55-year-olds and 45-year-olds. And if we're going to begin investing, we should start with that population first. The legislature, though, some in the legislature are saying it should be 55 or lower, and there's going to be a negotiation.
and is this
debate.
the Medi-Cal? Forgive me if I got lost here. Is this the Medi-Cal population we're talking about?
Yes, Medi-Cal.
So I guess the piece that I'm trying to process here is, I know from my own experience and from the information you've shared that the political sensitivity is around providing government-funded programs for people who are in the country and who are undocumented, yes?
Yes, that's
okay.
correct.
So I guess my question is, I mean, did the state choose young people and or seniors because they think they're a more sympathetic population or based on some medical assessment of need?
So I think they went with young people first because there's incredible cost effectiveness. Small amounts of money invested in children can pay massive dividends later on in terms of health status and avoided cost, and they are relatively inexpensive as a population to treat. So that was the initial rationale. And I can't speak for the administration. I haven't seen their full explanation, but I'm assuming that the 65 plus has something also to do with the dual eligible populations, the effort to kind of tackle the aging population. The governor also has a master plan for aging that he endorsed this last year. So if I were to speculate about why the administration may have gone to this older population, it may have something to do, again, with need, maybe. It probably also has something to do maybe with their effort to get dual eligibles serviced through this larger system they're trying to create and through their master plan on aging. That may be their thinking, but I can't speak for them.
Thank you. If you hear more, learn more about the
Yes.
sort of the rationale, I would be interested to hear it.
I will include that in
Thank
the future report. So the last very short item, and this just underscores the extent to which the state is moving in the direction of the managed care plans in Medi-Cal, which again in Cal-AIM, that was very clearly the direction. Now another example of that is the governor's proposed what he calls a new public option, big part of the national debate about single payer versus public option. He wants to create a public option through Covered California, leveraging, as he puts it in his budget address, the managed care plans. The public plans, kind of having them collaborate together and in some fashion on a regional basis become, through Covered California, another option, a public option. It doesn't quite seem to meet the classic definition of what a public option is, but we have to see more of the detail before we can fully judge it. But the main reason I mention this is that it underscores, again, the extent to which the governor is moving in the direction of relying upon these managed care plans to deliver care in California.
I will just say as a passing observation, I think the governor is struggling to have any of these proposals get much public engagement or traction just because everybody's distracted by events in Washington, D.C. I mean, I'm just thinking back to a different time, 5, 10, 15 years ago. I think on the healthcare front, proposals of this sort would have been much discussed, intriguing to people, and, it's sort of just going by folks unless,
And that's a correct point. And one thing I would add to that is I've only touched on 3 of maybe 15 or 20 proposals. He has a number of public health initiatives, behavioral health initiatives. So on the plus side, he's being very aggressive across the board in health, but it's hard to get people's attention. That's the point you're raising.
Governor Brown, of course, was very purposeful and very disciplined about how he spent his political capital and focusing on relatively smaller number of items at any one time and sort of picking his shots, for lack of a better. Right. I do have one question, if you're at the conclusion, which is to go back to what was Texas versus Azar and is now Texas versus the United States. And the first thing I have to say is you can't help but say Texas versus the United States without smiling. I mean, that's just a sort of an intriguing notion. But I'm trying to think through the implications of the fact that, as you described for us, the case has been sent back down to the lower court, delaying any possible consideration at the U.S. Supreme Court, if I heard you correctly, until the next session in 2021, yes?
That seems to be the case, yes.
Now, for those of us who have been concerned about the lack of stability in the Affordable Care Act, is that delay good news or bad news? Good news in the sense that it doesn't sound like anything that's the last word, and that does some damage, can happen for close to another couple of years. Bad news in the sense that we're still sitting here wondering whether the whole thing's going to crater eventually.
So Attorney General Becerra and his colleagues in the other states that have been litigating this would argue that it's bad news because they want certainty in the healthcare system, and they argued to the court that they needed to expedite consideration of this because we shouldn't have to live for another year with uncertainty. Again, the ACA is not collapsing because of this uncertainty, but the more unstable it is, even on the margins, the more likely it is that certain people don't choose to be covered in the ACA and that certain providers choose not to participate. Certain plans maybe make decisions that might be not advantageous to the system. So there are arguments on both sides. The other side of the equation, of course, is the threat of complete destruction is deferred. And sometimes in government, in politics, and in public policy, deferral is a good thing. So you could argue
and
both
in
sides.
And in life.
And in life.
Yeah.
Yes.
And denial's a tool we all use from time to time. So and just the very last piece of this, and so in the meantime, the individual status of the individual mandate is what again?
It is on the books but unenforced. And again, and as a consequence, we have no individual mandate from a financial penalty perspective. And the ACA, there have been some studies suggesting that some of the slippage in enrollment that occurred, and there has been slippage, is a result of that. But what some feared, which would be a collapse of the system, that hasn't happened.
That was
now,
the piece I was
over
heading
time, it might be a steady erosion. So it's still a relevant issue to debate and talk about. But the sudden collapse hasn't happened.
But the concern about a sudden collapse was predicated on the concern that in the absence of healthy folks being obliged to be part of the pool, insurers might say, well, I don't want a pool that's full of folks who are going to be nothing but costly. Am I remembering that right?
There's that, and also just the price would go up. The premiums would go up because suddenly you have a sicker population.
Okay. All right. Well, ordinarily this is when I would turn to my colleague and see if she had any questions, but not today. Again, her staff is here, and I know we all have appreciated the update. You always do a great job, Mr. McGowan, so thank you. And it'll be available on the tape for Supervisor Ellenberg as well.
Thank you very much.
Any last words before we adjourn? No? Then without objection, and I definitely hear none, we are adjourned. Thank you all very much. Take care.